my pleasure to be here and tell you about my perspectives on the future and also share a couple of complex cases. So I think the sweet spots for DCB only or the hybrid approach is where stents are not perfectly performing. We have already data on most of these scenarios: small vessels, diffuse disease, diabetics, especially multivessel disease, bifurcations, and CTO-PCI, as well as aneurysmatic vessels and calcified lesions. And one very important point is that if restenosis occurs after DCB only PCI, then you have all tools available for redo PCI. And also, among the most important and I think interesting patient population is the high bleeding risk patient, where we can shorten dual antiplatelet therapy or even use single antiplatelet therapy. But I would say that DS is not our enemy who are using primarily DCB. We need DS, and DS makes our DCB PCI safe. I think we need to go beyond challenging only DS, but use the combined approach using DCB and DS, maybe to challenge in the future cappage in multivessel treatment. This is a meta-analysis published a few years ago, showing still that cappage is the primary option, especially in patients with multivessel disease and diabetics. This is one early case we did over 10 years ago. This is LAD stenosis. It's a bifurcation lesion, and there is an aneurysm just before the lesion. And very simple and effective approach is to use a special balloon, in this case a cutting balloon, followed by a DCB-only approach using the paclitaxel-coated sequent please. And 11 years later, very good long-term result of this approach. Now, for further discussion, I will present a case, a complex case, where we could treat a young patient without leaving any metal behind. So this patient presented with STEMI, and you can see that there's an acute occlusion in the intermediate branch, and there's also a LAD CTO, what you can appreciate later in the second procedure. So after predilatation, the lesion was very long, and there is a left main bifurcation very close, very difficult to nail the ostium of the intermediate. A very effective way of treating this kind of patient with, again, a bifurcation lesion is to use DCB. And then we opted to stage, of course, the LAD CTO PCI within next 4 weeks. And this is the situation. You can see that there is an ambiguous proximal cap with a bifurcation lesion. We used IVUS-guided puncture of the proximal cap with Kyanext 3. The Kyanext 3 ended up in a subintimal space, so we did parallel wiring with Sasuke and another Kyanext 3 and entered the true lumen. Then we did some prelatations with a small balloon, and I will show that we have mostly intraplaque course of the wire, and this is very important if you are planning a DCB only approach in a CTO PCI. And diffuse distal disease. This is after predilatation of the proximal cap with a cutting balloon, and then you can see that there is still disease in the distal part, which where we subsequently ballooned with a small balloon. And then we did full DCB for the LAD. The rationale was that you always have the vessel in collapse in a CTO body or after the CTO body. It's a long lesion, it's a diffuse disease, it's a bifurcation lesion, and it's a young patient. We brought, this is the final result. You can see that there is a non-flow limiting dissection in the CTO body, but basically this fulfills the criteria of leaving nothing behind in this patient. We brought this patient back 4 months after the PCI, and you can see that IM branch is very nice, and then LAD, there is a marked positive remodeling, especially in place that we have this section. As we heard today, this section actually predicts more positive remodeling. Still, there is some healing in the vessel, but basically a good result for this young patient. So is the left main the final frontier for DCB? We were, I think, one of the first to publish register data together with Simon Ecclestoll's group, so we were pushing the envelope. This is a case from early times where we had a calcified distal left main lesion in an HPR patient, and successfully we treated this with DCB-only approach. And in our experience, especially the cases where we have calcium in the distal left main, we can have sufficient MLA controlled dissection and treat the patient with DCB. Quite often these patients are sick, they are high bleeding risk patients, they are cancer patients, they are patients requiring urgent surgery. And in these two papers, no single acute closure of the vessels. Now we are collecting more data together with Simon and also Professor Shin about this approach. I would like to share another case. This is a calcified left main distal lesion with circ involvement. And as you know from many bifurcation trials, like October trial, which also look at the use of intravascular imaging, the side branch ostium, especially the circ ostium, is the most prone place for wrist stenosis. So maybe DCB-only approach is also something that we could use in this kind of scenario. So what it usually requires is quite aggressive calcium debulking to have sufficient MLA in a calcified lesion, and thereafter many times for ostial lesions we use a cutting balloon approach. And this is after predilatation. You can see that there's less than 30% recoil in angio. And then, as discussed before today, sequential DCB treatments. Quite often we also treat the moderate disease in the other branch. You can argue that you could leave the LAD alone, but we put also drug there. This is the initial result. There is dissection in the left main, which is not accumulating any contrast. The flow is good, the patient is fine, and very importantly, MLA with imaging is sufficient in this case. And again, 2 months after DCB-only PCI, there is positive remodeling. If there will be restenosis, which I'm not will be the case in the future, you still have all the tools to engage this lesion. So in conclusion, I think PCI using the hybrid approach could really challenge CABG in the multivessel treatment in the future, especially combined with intravascular imaging. And maybe the next step is to use DCB in combination with payload scaffolds for true leave nothing behind PCI approach. We all need stents or scaffolds, I think 10 to 20% of cases, so they are very important for safety. And maybe for diffuse disease and CTO PCI, we could sometimes consider doing stage procedures to not to over dilate the vessel and not to be too aggressive in the first PCI, bring the patient back and then do more work, because the blood flow will increase also the vessel size. And then about the choice of the truck, we have now we have 3 trucks, but at least 2 major ones. I think there are pros and cons. Paclitaxel may have a role in preventive PCI, in vulnerable plaques. They both can be used in many situations with no clinical difference, but maybe paclitaxel could be preferred after a little bit suboptimal predilatation result because it has more positive remodeling effect. And maybe sirolimus is a preferred one after stent-like predilatation result, and especially after extensive dissections during the CTO-PCI, because we know that in CTO-PCI, subintimal paclitaxel has a risk of aneurysm formation. And maybe in some situations where we have already diminished flow in the vessel, we should prefer non-crystalline DCBs not to have any risk of distal embolization, which could still reduce the flow. And then maybe the combination of the trucks could be also one potential application to improve outcomes. We don't know this yet, but there is, I think, companies starting now developing these kind of products. So thank you for your attention.